Good afternoon, everyone, and welcome to UCSF Family and Community Medicine Grand Rounds. We are very excited to have a wonderful presentation today. Today's session is entitled Advancing Healthcare and Economic Development in Indian Country. And our speakers today are Tyler Evans and Mark Echo Hawk. And just as a reminder for those of you who haven't joined us before, today's session is being recorded. If you'd like to see this session again or other previous grand rounds that you may have missed, you can find us on the UCSF Department of Family and Community Medicine Grand Rounds website, and you can watch this session or any other previous sessions that are all uploaded. If you have feedback about today's session, or if you are interested and have topics for suggestions for other sessions, please, by all means, send us your suggestions by putting them into the Q&A or filling out the evaluation forms. We're hoping that today will be a very interactive session, so please add your comments using the Q&A for our speakers today, who will address your questions or just so that we can hear your comments. As always, before we get started, I want to give my special thanks to our tech team, to Benjamin Wallen, Mark Wooding, and of course to Roy Johnston, who helps, as always, keep these sessions together. So with no further ado, I want to welcome our speakers today, who, as I mentioned before, are Tyler Evans and Mark Echo Hawk. Tyler is the CEO and co-founder of Wellness Equity. Tyler is the CEO and co-founder of Wellness Equity Alliance, which is a group dedicated to transforming public health delivery to marginalized communities. He's a physician who's a specialist in infectious disease and public health, and he's based locally here in the Bay Area. Tyler spent his career working in either community or public health settings in both the U.S. and global South, largely addressing the health inequities that are socially and politically determined. Tyler was previously a medical officer and the community health director with the Indian Health Service on the Wind River Reservation, serving the eastern Shoshone and northern Arapaho in Wyoming. He served in a number of war zones, public health emergencies, and complex humanitarian emergencies abroad and domestically, including serving as first chief medical officer for New York City during the 2020 COVID pandemic. Tyler was also the deputy public health officer and the COVID vaccine incident commander for Marin County, and has served as one of the operational lead advisors for the Association of Bay Area Health Officers. He also, excitingly, has recently authored a book that will soon be released entitled, quote, Pandemics, Poverty, and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19. Our other speaker joining us today, who I'm really glad will be part of our discussion, is Mark Echo Hawk. Mark is an enrolled member of the Pawnee tribe and co-founder and managing principal of First Sovereign Health. Mark is a tribal attorney. He's an enrolled member of the Pawnee Nation, and he represents Indian tribes. He's advocated for tribes for 24 years, helping them with governance affairs and economic development endeavors. From treaty rights to taxation and everything in between, Mark helps tribal governments protect and advance tribal sovereignty. In addition to representing tribes in traditional economic development matters like gaming and smoke shops, Mark has helped tribes develop innovative economic development options, leveraging tribes' sovereign status and regulatory advantages. Helping tribes address pressing healthcare needs in new ways that generate additional tribe revenue has been one of his most rewarding professional achievements, and we are delighted to have both Mark and Tyler here to talk with us today. So thank you for joining us.
Well, thanks, Marco. Appreciate it. So we're really excited to be here today. I think we've been planning this for over a year. This talk is really approaching, one particular community, in indigenous communities, which actually is a much larger group than just one sort of monolith. So it's important to recognize the variability within that context or that definition. But we have seen a relatively static model of healthcare delivery to this group really for over 100 years, and so we're really excited about sharing our innovative model on how to improve healthcare delivery to Indigenous communities throughout the U.S. and not just improve the healthcare outcomes, which will obviously be improved with respect to access, but also improve economic development for the tribes, and really kind of bringing together that sort of Venn diagram of these two sort of outcomes and getting ultimately to self-determination, which is really key for Indian country. So with that, I'm going to share a little bit about our organization, Wellness Equity Alliance, and kind of get people to understand, how we sort of got to this space, as the result of some of our models, again, kind of thinking differently about healthcare. And really it was mostly the pandemic that sort of brought us to that, brought us here essentially. So this is our agenda. We're going to talk a little bit about our organization, and importantly, I'm talking about Wellness Equity Alliance, which is a multi-state group. But Mark Echohawk and myself, as well as a few of our partners, have also formed another organization company called Sovereign Wellness. And the work that we're going to be talking about in Indian country is the result of that company. And then so we're going to talk a little bit about existing Indigenous healthcare systems, mostly through Indian Health Service. And then we're going to talk about our approach, which is the off-reservation 638 tribal health centers, and then a little bit about how we do it. And then finally, we'll leave with why it's important. So, again, a little bit about us. We were formed during the in the height of the COVID pandemic. I had rolled off of working as the first chief medical officer for New York City, overseeing COVID operations. I had thousands of people working underneath me, and as the result of all of these resources and all this access, we still had a lot of challenges engaging a lot of historically marginalized communities, and went back to California, which was home to the Bay, to help stand up mass immunizations. I had been working in a lot of sort of complex war zones, humanitarian emergencies, worked on the Ebola response twice. So, had seen things a little bit differently. And so when the pandemic emerged, which, I had this previously totally useless skill set, which was understanding the difference between isolation and quarantine, and mass immunizations turned out to be pretty useful. So, after being in the Bay Area, working with ABAHO, Association of Bay Area Health Officers, and standing up some of those programs, we jumped into an organization called Curative. I was asked to ultimately lead the company. We brought on over 2,000 clinicians over the course of 7 months, and what we're really proud of, we're not only just being able to scale, essentially public health extension models, responding to public health emergencies, but we were also really able to focus on equity-centric models, and really focus on the folks that were most at risk of COVID-19 and all of the sort of intersectional elements of COVID, looking at things from a syndemic standpoint. So we administered over 2 million COVID vaccines. We did over 1 million in California. We had some operations even in the Bay. And then we wound down that, we're also on the southern border of Texas. I'll talk a little bit about that, as well as places like Flint, Michigan. And then we wound down that organization, and we formed Wellness Equity Alliance a little over 3 years ago. So we're still sort of toddlers in the space. And it was a bunch of docs pretty much that formed the organization. And a lot of us didn't really understand much about, running a business or healthcare finance, but so it was a steep learning curve, but we, have figured it out at this point. We never took any VC funding. We just bootstrapped it ourselves, and now are working in a number of states. These are some of the areas that we're working in. Behavioral health is a big focus of ours, including mental health and substance use, and then of course integration of primary care, and we're now starting to incorporate oral health into some of our programs. And so this is sort of a list of some of our current programs that we're working on. Street medicine, particularly HIV street medicine, combining that with integration with behavioral health, but still keeping the primary care element is kind of our special sauce, and that's what we're focusing on down in Southern California. We also have some reentry programs that we're standing up. Have also been working with the reentry population down in LA, and then also working as public health extenders. I was formerly the public health officer for the city of Vernon, helping them to get their public health department up and running, and then school-based health centers and obviously tribal health centers. And this is a list of the folks that we serve. Really proud of that. We often say that probably over a third of the U.S. Just cannot or will not access healthcare in the way that it's currently set up, and much of that is both socially and politically determined. So we just have to really think differently about these communities, and this is why we're here talking about Indigenous communities. So big program of ours. We're here at UCSF, so we're talking about our California programs. Very relatable. I was briefly the medical director for Alameda County's Healthcare for the Homeless, so was overseeing a number of street medicine programs in the Bay. And that, in addition to a lot of the other work that I had worked on in other places throughout the world, really inspired me to me and others to really look at ways that we could provide access to some of the most historically marginalized, particularly the unsheltered, unhoused. And now working really, really closely with groups like USC Street Medicine and other groups in Southern California, we've really been inspired and kind of helped build our program a little bit more. But why we're a little bit different is we approach things from a syndemic standpoint, and I think most folks probably know what that is at this point. If you don't, we'd love to talk about it afterwards, or send me a message. But so the syndemic approach really looks at infectious disease outbreaks or particularly epidemics, and frames it not as kind of operating in a vacuum, but looks at all of the sort of the synergy of the other sort of colliding impacts and other epidemics that are working along with it, like your viral hepatitis, like your STIs, et cetera. And then having other drivers like behavioral health usually being a core element of that, particularly addiction, and then seeing how the social determinants kind of fuel it all. So the syndemic approach is really increasingly gaining more steam. A lot more programs are funded through the sort of the syndemic departments that we're actually seeing structured public health departments coming up through the syndemic bureaus and whatnot, like in New York City. Through this approach, if we apply syndemic approach to street medicine, it's really a great way to bring public health and clinical services or healthcare into one fold. Both of these groups have spent most of their lives, careers working on this issue. And street medicine, we really believe, is that connective tissue that can kind of bring these two into the same fold, and particularly HIV street medicine. And so with this multi-specialty model of having primary care providers who are trained also in HIV treatment and prevention, as well as other intersectional infections, as well as behavioral health with a big focus on addiction, we can really have meaningful responses to some of these communities in encampments, and link it to public health emergency preparedness, TB management, STI management, particularly the constantly emerging syphilis epidemic that's seen particularly among women. And so why do we do it? It's just ultimately when it comes to HIV, when it comes to the EHE and the HIV epidemic goals, one of the most intractable communities has been the unsheltered and unhoused. So we just have to do things differently. We think now with the long-acting injectables coming out, particularly with respect to prevention, there is, I don't have any disclosures. I don't work for a pharmaceutical company. We really think that we could really have impact on the 90-90-90 goals, and really kind of get kind of push the needle on that, and really mitigate the risk of transmission. Not just keep people out of the hospital, but get people housed and reduce and mitigate and prevent the risk of HIV transmission. So those are a few kind of our programs, just examples of what we're doing. We've got a program down in South Central Los Angeles. Again, this is our modalities that we are providing. We start with a social determinants data-driven heat map with a bunch of different data sets on the social determinants like the SVI, and then using ArcGIS, we can look at human mobility data to see where people are spending their time, and then we could code that and identify the risk for HIV transmission or opioid overdose. There are some barriers with that, but we're working through that. This is our catchment area here between Skid Row, basically, and Martin Luther King Hospital, which is around Compton. Funding's important. Never really understood how important that was running an organization. So we really have to be as innovative, creative as possible with funding. So we are doing that, through CalAIM dollars, enhanced care management, Some of the health plans are now going to be providing reimbursement for direct street medicine services, so that's great. And then looking at other, federal grant opportunities like SAMHSA, HRSA. Palm Springs, Coachella Valley, another example of our program, very similar approach, totally different context. So we really call this like desert medicine more than street medicine. It's the best way to describe it, sort of Breaking Bad meets Mad Max. And this is our area here. Palm Springs, Coachella Valley, place where most folks are going for leisure. I'm one of the only people who fly down from the Bay to go work. But we're having great experience with the communities and really feel like we're having an impact. I'm here in New Mexico right now. We're standing up a school-based health center program to focus on access for at-risk youth. It's going to be based upon mobile units, really large rigs that are going to be focusing on behavioral health and other elements of primary care for youth, particularly sexual health, gender affirming care, and really seeing how we could sort of bridge the gap between healthcare and educational outcomes. We're also standing up a reentry program here in Bernalillo County, that's Albuquerque and the surrounding area, and then focusing that around substance use, working on both pre and post release. And really ensuring we're looking at the sort of the continuum and seeing how that sort of connects to housing and security. We were down on southern border of Texas, like I mentioned, working with a number of groups, particularly asylum seekers and the colonias, which are close to 2 million people living in unincorporated villages around the southern border, particularly around Texas and New Mexico. Not a lot of and California, actually. There's not a lot of folks know about them, which is really unfortunate. It's basically a human rights violation. A lot of these folks have absolutely no access to anything, particularly healthcare. So we're really proud of that. And this is an example of one of our heat maps that we were using around Laredo to identify where we were going to focus our COVID-19 vaccination campaign. And then we stood up some community paramedicine, some technical assistance around community paramedicine and community health worker group focused on COVID-19 disparities in rural Missouri. We worked in Austin, Texas, working with the health department there, working on MPOX and then connecting those folks into sexual health and primary care services. So we were really proud of that. So just kind of gives folks, an idea of all the different areas that we've been working in and why that kind of culminated into us working in this particular space. Again, working with communities that for many reasons have essentially been forgotten. And, these sort of static healthcare models that currently exist. And Mark's going to talk a little bit about why they exist and the sort of history and the genesis of them. They just don't work. And as the result of their sort of dysfunction, the American Indians, Alaska Natives have some of the worst health indicators in the country. So with that, I'm going to give it to Mark.
Thanks, Tyler. Organizations like WIA can be game changers for Indian tribes. I'd like to talk a little bit about the historical delivery of healthcare to tribes in our country, and focus the conversation not just on how healthcare has been delivered to tribes, but how tribes can be involved in delivering care to their own members and other communities. So I'd like to first start with this oddity of how the federal government got to deal with Indians in our country and healthcare. Early on at the inception of our nation, we had, of course, the Department of War was in charge of interactions with Indian tribes, and they made treaties with tribes that were political in nature, treaties between the U.S. government and tribal governments, and they provided for healthcare services. And you'd have military personnel delivering those healthcare services to tribes. And so Indian tribes for a long time were receiving healthcare through the Department of War, which wasn't a real feel-good to tribes in terms of healthcare delivery. In the 1850 timeframe, that changed when the United States government created the Department of Interior. And the Department of Interior was the branch of the federal government that was responsible for undertaking the federal government's responsibility with regard to tribes. And federal government created the Bureau of Indian Affairs that undertook primary responsibility for tribes. Later, the federal government created, as part of the Department of Health and Human Services, next slide, Tyler, the Indian Health Service, which was an agency focused specifically on providing healthcare to Indian tribes. and undertaking the responsibility of the federal government to live up to its treaty obligations. And let me pause for just a moment here and explain why that matters. You know, the United States Code has a title. Title 25 is entitled Indians. And we know that it is not allowed in our legal system to make laws based on race. So why would it be okay to have a whole title of the US Code addressing an agency of the federal government delivering care to Indians? There's a plethora of laws, federal laws, that address tribes, tribal matters, healthcare for tribal members, but it is allowable because the relationship between tribes in the United States is political, not racial. That's something the U.S. Supreme Court determined years ago. So the Indian Health Service became, in the 1955 timeframe, the agency that started dealing with tribes and healthcare, and it has this large presence amongst the nation. There are 574 federally recognized tribes, and across all of these reservations throughout the nation, Indian Health Service is very involved in healthcare. Next, a large piece of the federal framework that regulates how the federal government deals with tribes on healthcare is the Indian Self-Determination Education Assistance Act. I'll refer to it as ISDA. In 1975, Congress took action to address problems that it was having in Indian country. And there was, real striking demographic challenges, poverty, suicide rates, healthcare challenges. And so Congress took action, and it could take action because as the law developed in the United States, Congress was recognized as having what they call plenary authority over Indian affairs. Congress is big boss when it comes to everything about Indian affairs. It can change the game entirely anytime, and it has. Over the course of time, in 1975, they took decisive action to say we need to deal with some of these problems by letting tribes become involved in healthcare. And when a tribe felt like it was ready to exercise its sovereignty and help solve some of its own healthcare problems because of deficiencies in the delivery of care by the Indian Health Service, tribes under this law could take action to use federal funds that were being dedicated to fulfill these treaty obligations that the federal government had to tribes in healthcare. And they could enter contracts with the Indian Health Service under this Public Law 93-638. So I'm going to be talking about these contracts. I'll refer to them as 638 contracts. It just means a contract, an agreement between a tribe and the United States Indian Health Service under that Public Law 93-638. So Congress gave tribes a tool to start to deal with healthcare. There's been a big change, next slide, in the policy of the federal government towards tribes. I just talked about ISDA, number 6 there, and that's the order of the day. That's self-determination, self-governance, economic self-sufficiency, where the federal government fosters the development of tribal governments and their involvement in healthcare and other matters. That's not always been the case. Of course, if you think back in our history, originally Congress said, hey, we have treaties with tribes and no one gets to deal with tribes but Congress. We had a big shift in the approach of the US government dealing with tribes from, the initial doctrine of discovery. Hey, we discovered America, tribes don't, they don't have any rights here because it's our land and we're going to use it. And they would remove tribes from their reservations. At one point in our history, in the late 1800s, the federal government shifted to trying to assimilate tribes, mainstream them so that they didn't have to deal with reservation issues. That proved to be a disaster. And then in the 1950 timeframe, Congress just said, let's just do away with tribes. And that was known as the termination era. Tribes lost their connection to the federal government. This is when Congress walked away from its treaty obligations, its fiduciary or trust responsibility to tribes. That turned out to not work well as a policy mechanism, and it's not happenstance that ended about the time as we started to see civil rights becoming a recognized issue and emphasis in the United States. Since 1961 to the present, regardless of which political party has been in charge in Washington, we've seen every presidential administration and Congress follow this policy of self-determination, self-governance. So things could change because Congress has the authority, and it could take a different approach, but it is not likely, given that the policy has evolved and been in place for so long. So, we're operating under this scenario where the federal government supports the existence of tribal governments. So let's now talk about how healthcare is implemented under these 638 contracts by tribes on the reservation. So the typical approach is that tribes step in and say, hey, IHS, we don't really like how you're providing care to our members. We're going to do it using federal money. Let's get a 638 contract in place. And I would say, most tribes have some kind of 638 contract. Maybe half tribes have stepped in to do 638 contracts for healthcare, but always on reservation, always focused on tribal members in their communities. And even though they could do more, that's just been the typical approach. And the funding that's available through 638 contracts has always been insufficient. And it's hard to attract providers to these reservation locations that most times are remote. Across the nation, you have reservations located further from populations than you do in California. It's hard to bring people out to reservations, and they have isolated facilities, and it's hard to staff up these tribal clinics, even if they have a 638 contract. So under the historical approach, tribes continue to have, and still to this day, most tribes have health challenges that aren't being solved by either IHS or tribes under the classic scenario of 638 contracting. That can be very different, though, which is really the focus of our conversation here. And I'd like to talk next about the evolution of how ISDA 638 contracting is being implemented now off reservation by some tribes. Next slide. So over a decade ago, we took this new concept to the Department of Health and Human Services, working with IHS, and said, hey, tribes aren't always under the law. They don't have to have a clinic on the reservation. They can go off reservation to provide care, even though they don't own the land. They can enter these 638 contracts, and they don't necessarily have to be on reservations. They can serve more than just tribal members. Congress passed the Indian Healthcare Improvement Act, and that allowed tribes to serve non-Indians in their communities. They're referred to as non-beneficiaries, or not the intended beneficiaries of the federal laws. The intended beneficiaries would be tribal members. And so tribes had the legal framework, and no one had ever really used it to do off-reservation 638 clinics that primarily served tribal members, but also served non-tribal members, as long as the service to non-tribal members didn't diminish priority services that tribal members could get. And so starting about a decade ago, it was a novel concept. We started to work, through the top levels of IHS, HHS, to get approval for off-reservation 638 tribal health clinics that could serve tribal members and non-Indians that are eligible for Medicaid. And they could, because they're serving Medicaid eligible patients, they could do third-party billing and bring Medicaid funds into their clinics. They have to use those funds for healthcare purposes, but now they had a way to provide care with additional revenue, because there was never enough under the IHS system. Now, this is an important concept because tribal economic development opportunities have really been dwindling lately. Next slide, you'll see that gaming is just an example of one kind of economic development. Tribes had lots of opportunities. Some tribes, not very many actually, but some tribes were positioned next to metropolitan areas in a state that allowed some kind of gaming, so they could do gaming too. And so you had some tribal casinos that, there was, I would say, kind of a heyday where that was a way that some tribes could earn revenue. And they would, when they earned revenue, they'd be able to provide essential government services like healthcare to their members to supplement what IHS funding was not providing. But that has been dwindling with the development of online gaming. There's been a real shift in revenue streams that are available to tribes. All of a sudden, then, these off-reservation healthcare, 638 healthcare facilities that can serve non-Indians at an advantaged rate, we'll talk more about in a little bit, they can charge much higher a reimbursement rate than most people for Medicaid services to Medicaid eligible patients, including non-Indians. And all of a sudden, they have the opportunity now, because of this advantaged reimbursement rate, to generate a lot of revenue for their members in the healthcare space and use it for healthcare purposes. So let's focus now on talking about the existing Indigenous healthcare delivery system problem and fixes. Tyler?
Thanks, Mark. So, so we talked a little bit about, the sort of the genesis of the current infrastructure that provides these services, mostly through IHS or through the 638 tribal sort of carve out. And so this is looking at maps of California and Idaho, for example, and looking at the sort of the HIPS or the health professional shortage areas. I know folks here looking at some of the, usually in any good epidemiologist knows that darker is usually bad. And so you could probably make it out that essentially the darker areas are where we're going to see a little bit more of the shortage areas. So lots of, in California, lots of inequities, and a fair amount of tribal communities living throughout California, as is the case with Idaho. Again, these are two states that we are standing up programs in, and so lots of challenges, but lots of opportunities. And so we'll be talking a little bit about what that looks like. But typically what you'll see in terms of clinical services is you got your kind of standard IHS clinics, which many of them were literally created in the 1950s and 1960s. They haven't changed those facilities for much at all. I used to work in one of them, very gray, very beige. I was the community health director at the Wind River Reservation with Northern Arapaho and Eastern Shoshone. And then interestingly, one of the Northern Arapaho ended up going the 638 route. The Eastern Shoshone kept the IHS model. Northern Arapaho are doing very well, and Eastern Shoshone continue to have sort of struggles. So limited scope of services for sure, pretty much just focusing on primary care. Specialty care is almost impossible. If they do refer out, if they do have Medicaid, it's a little bit easier. But if not, then it comes out of the IHS budget, and essentially you have to, the IHS clinical staff will ultimately make a determination, sort of like a utilization sort of management, and determine whether or not this patient is appropriate to send them off. A lot of these facilities are in very rural areas. So like, for example, when I was in rural Wyoming, the closest academic medical center was 5 to 5.5 hours away in either Denver or Salt Lake City, respectively. A lot of substandard care. The cost and coverage is an issue. The hospitals that are on reservations are underfunded for sure. One of the biggest issues though is workforce. You'll get a lot of folks that are coming out of their residency or fellowship, and they want to go out and go change the world. I was one of them. And then you get there and it's this dystopian world. You see all of the dysfunction in this system. I mean, when I was out there, I was, having a public health background. I was the main epidemiologist, and I would run the data, and our mean survival was 54 years. 54 years. I mean, that's what we'll see in Central Africa, and the majority of of that mortality was attributed to substance use. So we'll talk a little bit about why that matters. So just tons of gaps, underfunded. It doesn't, but most importantly, it doesn't speak to the communities. So there are generations of historical trauma that have been, that are constantly triggered as the result of these models that are the result of war. It was formed under the Department of War. And you'll have folks that are coming as members of the Uniform Public Health Service that are coming in uniforms and reminding tribal members of these historical generations of trauma. And so, some of our no-show rates were just astounding. I mean, it would be greater than 50% no-show rates. So we would have to max pack these services in. So no doubt that we have to think differently. The mean appointment time, the access is a serious challenge. I mean, sometimes for primary care, it'll take over a month to get in. Urgent care, maybe a few days. Obviously, given the need of urgency, that's not going to work. And so as a result of both access, as well as other elements, many of which are socially determined, American Indians, Alaskan Natives, have the worst healthcare outcomes in the country. They have the highest risk of cancer, of liver disease, much of which is contributed to by alcohol, diabetes, obesity. There are case studies, very well known amongst like the Pima in Arizona. Mental health, substance use, the risk factors are significant. And so, as a very kind of discrete and concrete outcome of these inequities, life expectancy is the worst among all populations in the United States. American Indians, Alaskan Natives, mean survival is 71.8 years. That's more than 5 years less than their respective non-Hispanic whites. There's something wrong with that. Women, as usual, are outpacing their male counterparts. Men at 68 years. 68 years. Again, in the tribe that I was at, that number was more than 10 years less than that. So this is the reality of where we're at, right? This is the problem, and given these issues with survival, when I was working with IHS with at the Wind River Res, which was about 10 years ago, I wrote this paper op-ed because I saw this sort of overwhelming almost fixation with obituaries. When we see in sort of urban settings in the United States, that I've grew up in California, New York. I mean, typically people are talking about, what are you doing this weekend? Oh, we're going to graduation. We're going to a wedding. We're going to this. It was often obituaries, and people would actually read the obits it was also funerals, and people would read the obituaries to actually plan out their weekends or their months. And I thought that was just so sad and dystopian. And so I wrote this op-ed. I think it's still out there. Just Googled obsession with obituaries and my name. And then of course, when it came to the COVID pandemic, of course, we saw an amplification of those inequities, right? So we saw a significant disproportionate impact on these communities, basically up until age 69. We know that sort of starts to drop off after that age for a number of reasons. It's that sort of double jeopardy. I mean, folks are so resilient once they get to that point that they could survive anything. But consistently, COVID-19 infections were significantly higher. So that's the problem. And the purpose of this talk is not to just talk about the problem, it's talk about the solution. And that's why we're really having this conversation here. So as Mark had mentioned, the opportunity for us to really disrupt this model that has existed for decades and has led to just egregious outcomes is really exciting, right? We have this opportunity to really make change in these people's lives, and not just when it comes to healthcare, but also that economic development. And the tribes own this. So this is all self-determination, and ultimately leads to opportunities for them to build out their healthcare infrastructure and surrounding social services. So it's really a beautiful opportunity, provides all these additional revenue streams for them to sort of apply to. Job creation, workforce development. We're really excited about this, being able to put tribal members into respective colleges and universities, become medical assistants, nurses, you name it. Really, really excited about that. And then it's key to remember that the vast majority of folks are living off res now, right? They're moving off res because they need opportunities, versus these rural frontier areas that were constructed centuries ago. So folks are are integrating into cities, and there aren't health centers out there that can really speak to their needs, that make them feel like they belong. I've worked a lot with trans and non-binary communities, and we spend a lot of time making sure that the front office staff and the back office staff are folks of trans or non-binary experience, to make them feel like, hey, I know you, I'm a part of you. That's so key. So really having that cultural contextual component, and particularly community health needs assessment, which I'll talk about here in a sec, is key. But I'll pass this back to Mark to talk a little bit about how this is financed.
Thanks, Tyler. I just want to say that, as Tyler mentioned, the solution to a lot of these problems is off-reservation tribal 638 clinics. This is not an abstract concept. We've seen this in place for over a decade, and kind of a case in point, the Confederated Tribes of the Goshen Reservation, located about an hour and a half, 2 hours west of Salt Lake City, they had a non-reservation healthcare clinic in a small trailer, and they might have a provider visit every once in a while. And the members that didn't live on the reservation would have to drive hours to get out to the reservation. Very limited scope of care. The chairman of that tribe came to me as tribal attorney and said, we can't keep using the IHS system. It's not working. It's underfunded. We have to do something different. And so we sharpened our pencils and figured out a good solution here. And they have put it into practice. That same tribe now has 4 different healthcare facilities in Salt Lake City, 250 employees, 60 plus providers. They are generating revenue well above and beyond they don't even have to rely on the IHS funding, and they're serving a broad community, not just tribal members, but the homeless population, any Medicaid patients in Salt Lake that are usually turned away from other providers. And so we've seen this be a smashing success that a lot of other tribes are going to now. So what makes this work is the finance. So the federal medical assistance percentage is a reimbursement rate for Medicaid expenditures. Tribal facilities, if a tribe has a 638 contract, they get 100% of that FMAP reimbursement rate when they provide services to anybody that is eligible. This is both intended beneficiaries, tribal members, and non-beneficiaries. They don't have to be tribal members that are eligible for Medicaid. That 100% FMAP rate, also known as the all-inclusive rate, is at $719 per encounter. An encounter could be a flu shot per encounter with any discipline that they have in their 638 clinic. And that amount, I think when we started this 10 years ago, it was around $300. It's been climbing every year. And it's a very advantaged rate for encounters to Medicaid eligible patients compared to most providers that serve Medicaid patients. And I would note that it is the Centers for Medicaid, Medicare Services, CMS, and IHS that are helping tribes implement this through their 638 contracts. And those agencies, remember, have a legal obligation to tribes. The federal government has what's called a fiduciary obligation, a trust responsibility to tribes to help them implement these federal laws and carry out their healthcare responsibilities to their members and others if they choose to do that. One last note, next slide, on the IHS and CMS funding. The IHS still funds these off-reservation tribal clinics. It's called a secretarial amount. They hand over the money that they did use to provide the same kind of services that the tribe now contracts to provide. And then tribes also get contract support costs for the administrative costs of carrying out the contract, just like the federal government has. We had a recent Supreme Court case just a few weeks ago where the highest court in our nation said tribes also get to charge contract support costs to IHS for services provided to non-beneficiaries, not just tribal members, which was it should be a big infusion of additional revenue to the IHS budget, even though tribes don't necessarily have to rely on that alone now. So tribes get to supplement their IHS funding with third-party billing at this FMAP all-inclusive rate to Medicaid eligible patients, but they have some restrictions. The revenue they have, of course, has to be used for healthcare purposes. They're supposed to provide services within the 4 walls of their facility, though CMS is working really closely because of that fiduciary responsibility to tribes to facilitate how tribes dictate as sovereigns how they want to provide their care. For example, traditional healing practices by physician, not a physician, but a tribal elder that might give end-of-life counseling, or traditional diet advice as part of healthcare. Tribes are working with CMS right now in at least 4 different states. They do a state plan amendment to the Medicaid plan with the State Department of Health and Welfare that would allow for traditional healing practices to be billed also at that all-inclusive rate. And so they can really put their mark on what healthcare looks like in Indian country. Tyler?
Thanks. So, that's really why, I'm sure for the providers here, every doc needs a good lawyer, right? And And that's really why Mark and I and other principals have teamed up here to form Sovereign Wellness, because we're docs. We don't have the business and the legal chops to really kind of put this together. And with Mark and his colleagues' subject matter expertise, we can really taking this FMAP rate of $718. I mean, is really an opportunity. I mean, if folks that work in community health know that at best at a FQHC rate, you're going to get maybe 300, maybe 350. And you don't have the issues of same-day referrals. So behavioral health, for example, and primary care in the IBH model can see each other on the same day. So lots of opportunities. So based upon our CHINA's community health needs assessment, these are basically intended to be the major revenue generators here. Pretty much half and half primary care, behavioral health, and then oral health. And then based upon 30 to 200 plus encounters per day, this would be the revenue that it would ultimately generate. And so that's the money, which is important, particularly because of the tribe's need to make this as self-sustainable as possible. In terms of the clinical services, what we're really excited about is all of the multi-specialty model that really you cannot tell folks in these areas that go make that appointment over there 3 miles down the road between the hours of 9 to 5, and maybe you can get an appointment in 3 months. It's not gonna work, right? We know that for a number of communities, particularly indigenous communities, which have all these sort of systematic trust issues. It's not going to work. So we really need to have that multimodal specialty model, really providing all of those services in one package. So we're really excited to build out all of these different models, and other folks like Sacred Circle up in Utah that Mark was describing are doing that. And then we'll just continue to sort of build it out. And this is essentially how we build it. It's got to be phased out. You go in sort of incremental quarters. You first start with the CHINA, the community health needs assessment. We have the social determinants data sets like the SPI, area deprivation index, California with the healthy places index. Taking all those, we have over 100 different data sets that we can use, and then using ArcGIS, we can create these heat maps. That really tells us where the traffic is, where the access barriers, clusters of access barriers are. So super helpful. But it's also just stakeholder analysis as well. Where are you guys at, right? And where are we at in terms of the sort of stages of change? Then of course you get into the credentialing and all that jazz that we love doing. But it's important. And then the relationship building, super key. Among indigenous communities, you are an outsider until you develop those relationships, and making sure that you have folks that are, tribal elders, folks that are bringing you in is critical. Next, you go to the months 4 to 6, then you start designing and procuring the clinical facilities. You really customize the operational services to the needs of those communities based upon that needs assessment. Then the recruitment, that's not easy, right? In this particular space, workforce development, super key. And then you launch 7 to 9 months afterwards. And then you just keep on evaluating, and then expanding, and then scaling up, and then sort of rinse and repeat. So this is a little bit about what our CHINA looks like. It's a stepwise process. I talked a little bit about that. I think we all know about credentialing. That relationship building, so key. Got to make sure that you have your trusted messengers in the space. And then the capacity building. I mean, we're really excited to work with tribes that have had existing clinical services for decades, but to build capacity and really get the chops, not just in the clinical space, but also in the business management space, and help to educate them and help build out their skills to ensure that they can, they're employable, and they can kind of continue to sort of expand their efforts and really get to that point of self-determination. So workforce development, super key. Really excited about that. Of course, you got your standard workforce that we are going to be working on to develop. In addition to alternative healthcare professionals, which we in general strongly supports community health workers. We built out a national CHW task force. We have CHWs or case managers, a part of almost every program that we've got. We need folks that have the faith and the trust of their communities. They're not going to be trusting in somebody that looks like me. So we got to make sure that they have, particularly have lived experience, which is absolutely key. And particularly, we can take some of those CHWs and put them through a lay counselor training academy, and have them have the opportunity to actually have skills in terms of lay counseling, but they would be overseen by therapists and psychiatrists. And then finally, what we're excited about is building out a rotation of clinical personnel on res and off res. So folks that are off res, for example, in let's say a San Diego, we would then have them rotate to their on res once a month. We bring our dentists or our primary care or psychiatrists out there. So really, really exciting opportunity, and it's sustainable for the tribes because a lot of folks don't want to live in some rural area, but they will rotate in if it's part of their contract. So just leaving it off, why it matters, why are we doing this? Again, it's that Venn diagram of bringing economic development, improving access, and particularly outcomes, and then sort of folding that into self-determination for essentially the oldest communities that have lived on this continent. And it's our duty to help these folks, and we believe that over time this will become a self-sustainable model, and we will move out and let tribes do their own thing. So key takeaways here. Tribal healthcare in the US, it doesn't work. It is a static model that is based upon these sort of regressive policies. It was formed 70 years ago. It is not adapted over the time, and it's chronically underfunded and leads to very, very poor health indicators. We talked a little bit about how the many tribes have opted out of this direct clinical service through the 638 opt-out, but nearly all of that has been on-res. So we look at the Navajo, we look at many California tribes, Alaska tribes, they're doing really well, but they've only done this on-res. And with the majority of tribal members moving off-res, that doesn't sort of meet their needs. And then fifth, many tribes are facing increasing challenges in terms of sustainable revenue streams, like we talked about with gaming, right? So this is a great opportunity for tribes to again kind of achieve both ends. And then finally, these off-reservation 638 centers will meet a number of outcomes, including that workforce development. So in summary, Sovereign Wellness is really here to sort of disrupt the model. We really bring population, public health, community health services into one fold, improving outcomes for Indigenous communities, and really just focusing on that public-private partnership. I was a doc who worked most of my career working in the nonprofit or the government space. Worked many years in very complex areas in the global South. But at the end of the day, what I've learned is that for us to really scale and to really disrupt these antiquated models that hurt people, the public-private partnership is the way to go, and we can really provide those meaningful services to folks. So finally, the reason why we're giving this talk, right? Why are we here talking about something that probably a lot of folks are not thinking a lot about? It's because we want to activate your sense of what's possible, right? And B, we want to recruit you. We want to potentially try to see, how we can bring, dedicated and educated folks from, groups like UCSF, and continue to kind of think through these processes and build these out in different parts of the country. So please reach out to me or reach out to Mark. I don't think we have Mark's email information on here, but I'm sure we can get that information to you. But please reach out. We'd love to talk further and really make a difference. So I'm done, Margot. I think we have a few minutes for questions.
We do. And first and most importantly, I really want to thank you, Tyler and Mark, for a fantastic, really educational and exciting presentation with a lot to think about. We have some questions from folks that are here that I wanted to just share with you, and I know we only have a couple minutes. But the first question I wanted to ask was on behalf of Yuri, who asked, is there screening for social needs in these models, or are resources offered with the assumption that most, if not all, the patients have social needs? Thanks.
Yeah, so we screen quite a bit for ACEs. It really depends. It depends on the particular sort of context. But as a general rule, we'll screen for ACEs. We'll screen certainly for behavioral health components for PHQs, for GAD-7s, TAPs. We're doing a lot more of PrEP screeners, and then for social needs, specifically social needs as well. So yes.
Thank you. And then another participant asked, I think a really great question, a very important one, which was sexually transmitted infections are particularly challenging because of both the concerns about confidentiality and seeking care in a small community, and also because of the challenges or difficulties of county versus sovereign reporting and contact tracing in public health work on reservations. And so do you have any suggestions for tips or best practices addressing these particular challenges?
That's a great question. STI, I mean, when it comes to sexual health, I mean, really ensuring as much anonymity as possible is key. It's the best ways to go about it, particularly given the the required reporting of that data to the respective county or state health departments is complex. And I don't have a good answer in terms of the autonomy of tribal health to sort of not report out. As far as I'm still aware, we do have to report out that information, and we do. But again, we need to be as as anonymous and culturally sensitive as possible, particularly given given the stigma around this, and particularly without the education that a lot of Indigenous communities may have, particularly around sexual education. That stigma is profound.
Thank you for that answer. And then we really have time for just one more question. And it's not, admittedly, it is not a 3-minute question, which is the amount of time that we have left. But I wanted to ask anyway, because it's really related to that issue of trust and distrust. And the question that was on my mind was, how do we address all of the historical trauma and the just really, systematic distrust of different systems from Indigenous communities? I think your presentation sort of addressed many of these questions sort of indirectly, but I'm just curious if you have sort of an overall framework or just thought to leave us with in just the last couple of minutes. And I apologize, the time is so limited.
Well, it's a good doorknob question. And yeah, the difference always between an excellent question, that's an excellent question, and a good question is you have the answer to the excellent question. I think that yes, it's very complex, and it's, we could talk about that for hours. The easiest response to that is you have to have buy-in from the community. You have to have trusted messengers in there that are essentially kind of working with you and it's going to take time. Time is key. I mean, particularly with all of those centuries of historical distrust, nothing is going to happen like that. So having, folks that are coming from, San Francisco, New York, you cannot think in that sort of, with that velocity. You have to really kind of just deconstruct all of that and just, level set and again, just have those trusted messengers be your spokesfolks.
Thank you for sharing that. And Mark, I'm curious to hear your perspective as well, because you clearly bring a different professional experience and just different life experiences. I'm curious what your thoughts are about the issue of trust.
I would just add that tribal sovereignty works, respecting tribes' inherent sovereignty and allowing them to address problems that exist for their people. And there admittedly there has to be a new approach to the existing framework of federal laws and how they've been implemented to really give tribes space, but they have merits-based answers. When tribes are in charge of healthcare, they can do great things for their members. They start to address these big problems on reservations, and as their sovereignty grows, I think some of these problems with distrust start to melt away. When tribes are enabled because of economic self-sufficiency to dictate how they're going to act as a sovereign government and provide care to their members, they can really start to take up space and engage productively with state and local governments, federal agencies, and community members. So I think there is a fix, but it has to involve respect for tribal sovereignty.
Thank you. Thank you both, Mark and Tyler, for a fantastic presentation. You've given us a lot to think about, and hopefully this is just the beginning of our engagement and thinking about these really important issues. So appreciate your spending time with us today. Have a great afternoon, everyone. Good to see you. Thanks.
Thanks.
Bye-bye.